Good morning, everybody. I'm Dr. Nitin from Army Institute of Cardiothoracic Sciences in Pune. I'll be showing an interesting case. A young male soldier. He came to us with a history of inguinal chest pain at rest. In ECG-wise, he had end-STEMI and echo-wise ejection fraction of around 45% with some regional wall motion abnormality in the RCA territory. He had an angiogram done before he came to us. While he was on leave, he had gone to a outside hospital, got an angiogram done. It was a single vessel disease. So angiographic appearance, distal RCA showed a beaded appearance, appeared as a spontaneous coronary artery dissection. There were no classifying risk factors, and he had presented with ACS. He was relatively stable. There was no pain, hemodynamically stable. We thought that we'll give him a trial of conservative management and then repeat an angio after a month. We did because he had angina that time, class 2 angina. So we took him up for a repeat angio. The picture on angiography was similar. There was no change. So we thought we'll go ahead with an imaging guided PCI. So initially, we wired with a fielder FC into the PLV branch. PD was difficult to wire. Maybe we thought we were getting into the dissected plane, so we initially could only wire the PLV. Then we did an OCT pullback. So as this is the OCT pullback, here you can see some areas of maybe a false lumen and a true lumen over here. There is then there is a concentric lesion, a fibrocalcific lesion. Here you can see some clear demarcation between a false lumen and a true lumen, and a long fibrocalcific lesion that is extending right up to the mid RCA. There was here again you had multiple areas where you could see two lumens. So the various cross sections, here we see a true lumen and a false lumen can clearly be seen over here. Maybe an intraluminal hematoma. Now such imaging, sometimes another differential for this can be a recanalized thrombus, but we had waited for good amount of time from the acute period and there was no visible thrombus that was seen. So we made the diagnosis of a spontaneous dissection for him, and these are the distal reference and a proximal healthy segment that we had we decided as a landing zone for our stent. So initially we dilated with a compliant balloon. After that, with the difficulty, we could wire the PD with the fielder XT wire and then pre-dilated with the same balloon, and also because of the fibrous lesion we had used a scoring balloon and angiosculpt of 2.5 diameter. And then after preparing the bed, we went ahead with two stents. A distal RCA, we used a 2.528 and overlapped with a 328 Zine stent, and did the post dilatation with a 3 millimeter NC balloon. Then the post PCI run, it did not show any edge dissections, and there was some malapposition in the distal segment, and the proximal stent, as you see, was underexpanded. So here, after we corrected this malapposition and underexpansion with these are the cross-sectional images. Here you can see the struts that are hanging and clearly malapposed, both these cross-sectional images. So we corrected both the malapposition and the underexpansion with a high pressure 3 millimeter balloon, went up to 20 to 22 atmospheres, and this was our final result. We achieved TIMI3 flow in the vessel, and that was the final result. So take-home messages, spontaneous dissections, there is always a conservative approach that can be followed because most of these dissections heal unless and until the patient is in a hemodynamically unstable situation, or it's a left main where you need to maintain the flow as an emergency. Because dissection PCIs have low procedural success rate. You can have wire-related dissections. Wiring in the true lumen is the key, and imaging definitely helps you to ensure that you are in the true lumen. It helps you to characterize the lesion. It's imperative, I feel, to do image-guided PCI in such patients. Post PCI optimization, as in all cases of complex PCIs, improves the outcome. Thank you.